So this is one of our regular series of health focus events. We start off with a little bit of an overview from me about what's happening in the trust and what's going on. And then tonight we have a focus on research, and we have some brilliant speakers. We've got Siobhan, who's the clinical lead for research. She's been our director of research for quite a long time now and done some incredible stuff personally, but also really set up a good culture for research in the organisation. We've got Irina, who's been very directly involved in some of the COVID research and a number of other areas. Emma, who's looking at what it involves to take part in research. And then we're hearing not directly from the patient, but the mother of a patient who's been involved in a trial, which will be fantastic. So we will have a chance to ask some questions after each of the sections. And as Grace said, if you want to put any questions in the chat, then we can pick those up as well. We may answer them in the chat if we can, or we will say them out loud and respond at an appropriate moment when the presentation's finished. So that's the plan for this evening. Hopefully that's what you were expecting. So in terms of trust update, just in case, if we go on to the next slide, in case there are people who are new to Hampshire Hospitals, these are the principles that guide us. Our values are really important to us. They have spelt the word care for a number of years, about being compassionate, accountable, respectful and encouraging. And in the last year, we added inclusive to our values. We felt that our incredibly diverse workforce that we are so lucky to have, the way that we behave, we actually wanted inclusivity to be called out as a really core part of what it means to work at Hampshire Hospitals or to be cared for by Hampshire Hospitals. And so you can see in our little circle here, we've got our care values that our colleagues know really well, but with this inclusivity wraparound now. We also looked at our themes, our strategic priorities last year, and adapted them a bit from where we've been up till now. So we still retain number one. Our first strategic theme is about how we provide outstanding care for every patient. And we see that as the patients we're looking after now, but also the ones who will need our care in the future. And research that we're going to hear about tonight is a brilliant way that we actually live that value of thinking about the patients of the future and what outstanding care might look like for them. The second theme is about making Hampshire Hospitals a great place to work for our people. We have the most amazing people. You're going to hear from some of them tonight. And we want Hampshire Hospitals to be a place they can thrive, they can fulfill their potential. We then have working together for our population. Now, this was a new theme we added this year, which speaks to the role of the hospital as a partner with other players across Hampshire, looking at how we can improve the health and well-being of the people we serve. So not just about providing care when they're ill, but collaborating with partners on the things that will make a difference to their health and their life expectancy and their years lived in good health. Our fourth objective is around making the best use of our resources. We are funded by taxpayers, and it's really important that we spend every pound wisely. And so that's one of our key themes, is looking at how we use the resources we have available for the very best to optimize the care we can provide. And finally, about innovating for a sustainable future. And we've been trying to create a culture of innovation, of which research is a really important part, and looking at how we use the innovation that we have in our colleagues and in our systems to really put ourselves on the right foot for the future. And when I'm talking about where we're at the moment, I'm just going to pick out, I've got one slide on each of these 5 themes to give you a bit of a flavour of some of the things we're thinking about around each of those 5 themes. So, and just to position us, for anyone that doesn't know, we care for the people who live in roughly this geographical area. We operate out of 3 hospitals, Andover, Basingstoke and Winchester, that we run, but we also provide care in Alton Community Hospital, Eastleigh Health Hub, Newbury Community Hospital, and a range of GP practices, patients' homes, all sorts of other areas across this geography. And we also have patients that come from further afield than this for some of our super specialist services, particularly around liver and pseudomyxoma cancer that operate out of Basingstoke. So this geography is a rough approximation of the people we care for. And who are Hampshire Hospitals? Well, we have over 8,500 colleagues now, not all full-time. So you will see that that's that number in terms of full-time is slightly less than that. And the pictures here show you some of the specialties and some of the people that work for us. So the biggest group is nursing, midwifery and health visiting, predominantly nursing and midwifery for us. And then we've got healthcare assistants. We have huge numbers of estates and administrators and facilities, domestics, catering, portering that come into that category, as well as, of course, of our doctors, scientists, and so on, as well as our volunteers. So over 250 amazing volunteers that support us in all sorts of different ways. And the last bit of who we are really is our Council of Governors. So our Council of Governors, a number of whom are on the call tonight, which is fantastic, are representatives of the local community. They influence how our services are developed and delivered, what our strategic objectives should be, how all sorts of things fit together at Hampshire hospitals. We've got some photos here of some of our newest governors who have joined us in the last few months. We have 23 in total, 14 representing the public, 5 appointed, and 4 staff governors who represent different staff groups. One of whom here, John Ramage, that you can see his picture. I'm not sure if John's joined us, but he is also a big research advocate. So it's really nice that he's now on our governing Council of Governors. So bit of context, COVID, it hasn't gone away. You're going to hear a little bit more about it from our researchers. But I just wanted to share this graph, the bottom left, which shows since the beginning of the pandemic, how many patients we have had in beds in the hospital who are COVID positive. So the blue line was the very first year of COVID. And then 2021 was the red line when we saw our highest numbers. The numbers have slightly fallen off the side, but over 250 patients at one stage in 2021. 2022 was the green line, and you can see orange 2023. We've had the first couple of months of 2023, and we've been averaging around 70 patients in our hospitals for the this year, 2023 so far. So from our perspective, it absolutely hasn't gone away. 70, 80 patients out of a hospital bed base of around 900 is quite significant in terms of capacity and in terms of needing to keep those people safe and to stop the spread of COVID in our hospitals. So we are still asking people to wear masks in many areas of our hospitals, particularly clinical areas. That helps reduce the transmission. It also protects people who are clinically vulnerable, for whom catching COVID could have more severe consequences than for other people in the population. So it's really important that we do everything we can to keep our patients safe. And it's a little bit of a plug, but if you haven't had flu or COVID boosters, vaccines, please, I think you can still get them. You can find out how. It does make a huge difference to keeping you safe, but also those you love. So this is the first of my 5 slides about each of our themes. So the first one is around outstanding care. Pulling out a few bits here, planned care. So one of the things we've been focusing on is trying to bring down the waiting times following the massive build in waiting times over COVID. So in that very first year of COVID, we stopped a lot of planned healthcare across health services. So because we didn't have a vaccine, we didn't have ways of protecting people, surgery became much more risky, and also our clinicians were focusing on caring for COVID patients who needed to be in hospital. And what that did was build up a huge backlog, which we have since been trying to work through. One of our targets at the moment, this is just one of many measures, this looks at people who are waiting for surgery and have been waiting more than a year and a half. Now, we eliminated the waits of 2 years. We managed to achieve that. We are now focused on trying to make sure nobody's been waiting a year and a half, 78 weeks. And these are the numbers. In August, we had 406, August 21, down to 163 by August 22. And the latest number when we produced these was 140. We are committed to getting that to 0 by the end of March, and we have a plan that delivers that. We're then going to look at the people waiting over 65 weeks and then 52 weeks and so on to try and bring those waiting times down. Completely recognise it's not okay to wait that long for a planned healthcare intervention. Clearly, if what you need is urgent, and if it's cancer related, if it's life-saving, then those procedures we have continued to do in a very, very timely manner, immediate manner, pretty much throughout COVID. So these are for things that can wait, but probably, in an ideal world, wouldn't wait. Other things we're doing, so in terms of emergency care, you will all have heard the press about ambulances queuing outside hospitals, about long waits for an ambulance to get to you, about long waits in emergency departments. We have been really focused on trying to make sure that isn't the case for our population, and for the most part we don't have ambulances waiting. Now, today is not a good day to ask me this question, because this morning we did have ambulances waiting. Our hospitals were full. So we have, through the end of December, much of January, and then just again in the last week, have had every bed in the hospital full. We have opened extra beds in areas that were outpatient areas, including, I fear, in some of the space that used to be used for research, which isn't great for our research colleagues, but we have tried to look after the patients that needed caring for. We are working with partners to try and get people home when it's safe to get them home. And our ask here for the public is, if you are able to help bring a loved one, a family member home from hospital when they are fit to go home or ready to go home from hospital, then please, anything you can do to help us create some capacity for the new patients who are waiting at the emergency department and who need a bed. It is a real area of focus for us. Second theme is about making Hampshire Hospitals a great place to work for our people. Here's just a few pictures. I just want to start with probably the downside, the industrial action. Again, I've just this evening, we've heard that RCN isn't taking action next week. But in case you haven't seen it, the RCN, the Royal College of Nursing, which is the biggest union for nursing colleagues, they did not reach the threshold for industrial action at Hampshire hospitals. So we haven't had strikes of nurses, unlike neighbouring trusts where they did meet the threshold. So that we fully acknowledge the pain that people are feeling and the position people are in. It's just that specifically in Hampshire hospitals, we haven't had to manage that industrial action. Our physiotherapists did have a strike day a couple of weeks ago, and we've just heard this week that the junior doctors have met the threshold for strike action. So we're putting in plans around that. It is a big part of trying to make sure we support our colleagues, absolutely, and at the same time continue to provide care for our patients. On the slide, on the other stories, the happy pictures you can see here are from our People Awards. We had nearly 400 nominations for our People Awards, and we ran some tea parties. We're constantly looking for ways to celebrate our colleagues. Many of you will know about our WOW Awards, where you can nominate colleagues if you think they've done something particularly special. And we do that all year round, and we would encourage people to use that process. The People Awards was a kind of thing we're hoping will become an annual event, which is just another way of recognising the brilliant people we work with. And then couldn't do this in February without mentioning that it's LGBT History Month, and we've had lots of events going on at the Trust around that, and really thinking about how we support both colleagues and patients who are LGBT or part of this community. Sorry, I'm a bit distracted by some drawing on the screen. But yeah, it's how we support colleagues and patients. And we've got a brilliant champions group. We do have champions groups for lots of different diverse members of our staff, our workforce, and the LGBT group have done a fab job of putting on some brilliant events over February. So I just wanted to give them a shout out today. Third strategic objective is around working together for our population. We've got 3 examples here. One is the Andover Health Centre. So I think we had a counsellor from Test Valley, which was amazing, if joining us today. But we opened the doors to the new Andover Health Centre. That's the new GP practice. It's joined onto the Andover War Memorial Hospital site, and a brilliant capital investment replacing a very rundown building, working with primary care to do that. The virtual health hub, we could do a whole hour on that. It's a brilliant system whereby we've got hospital doctors, nurses, physios and colleagues working with community colleagues, with GPs and with the ambulance service. And it will do things linked to call before convey. So call before convey is if the ambulance service go out to a house and they see a patient that they think probably maybe could stay at home, then they could call the virtual health hub. They will say, this is the presentation, this is the symptoms, do you think they can stay at home? And virtual health can then contact community nurses or other people who are based in the community to go and visit the patient. There's a 2-hour response time, so those community teams can be in the house very quickly. That virtual health can also stay in touch with the patient over the next few days, request other services to go visit them, and effectively work collaboratively to keep people at home. Virtual health also does in-reach into care homes, so patients in care homes don't need to come into hospital, but can stay in their home, which is the care home, with the right level of supervision support from hospital professionals. And what we're trying to do is say, actually coming into hospital, it's a brilliant thing if that's where you need to be, but if you can be at home and receive the same level of support and care, actually most people would rather be at home. Coming on to making the best use of our resources. So as I say, we're funded by taxpayers. We need to spend that money wisely. One of the exciting projects that's happening at the moment, again out in Andover, is a community diagnostic centre where we've been given money from the centre to increase the diagnostic capability at Andover. So that means putting in more X-ray machines, more ultrasound machines, an MRI machine, permanent CT. We've had a CT out there for the last year or so, but the facilities around it, the kind of waiting area isn't great. Also endoscopy and a whole range of other things. As part of that, we are reconfiguring the minor injury unit and the maternity unit out there as well. So it's really exciting investment, which we've been able to attract that funding from the centre to provide. The little pictures and the infogram on the right hand side is slightly less positive. So our financial picture as a trust last year, our financial years 21-22, we lived within our money. We didn't spend more than we got, and we were able to provide the care within the budget allocated. It has not been the same in 22-23. And that is partly because the budget we were allocated as a hospital reduced, because some of the COVID funding was reduced. There was an expectation that we wouldn't need to spend so much money on COVID patients or COVID systems and processes. And on top of that, we've also had more people in hospital because of this issue of trying to get people home quickly when they're ready. So the length of stay, the amount of time people stay in hospital has increased. So all of those things have combined to mean that this year we are in a very much a red blob around the finances. Now we'll find out at the end of March exactly how red, but we've been very transparent with regulators and with commissioners and others that our financial position in 22-23 is not where we would want it to be. And we have launched a financial recovery plan, which is starting to show traction, but will take us into next financial year as well in order to get back within the funding we're allocated. And the fifth theme is innovating for a sustainable future. Let me start with Hampshire Together, because I just saw the chat pop up. I can't see all of the chat, but I saw something pop up about the new hospitals. So Hampshire Together is our new hospital programme. Many of you will know that in 2019, the government announced a building programme of 40 new hospitals across the country, and Hampshire Hospitals was one, or is one, of those 40. Since that autumn of 2019, there have been various things going on. We have been developing our proposals and our options, and the scheme for us is described as a new build hospital for Hampshire, and investment in the Royal Hampshire County Hospital in Winchester. You will know, and I'm happy to answer questions in the Q&A, but you will know that a year or two ago, we went out to the public and we've been clear about the new build site. There are two options, one on the current Basingstoke Hospital site and one near Junction 7 of the M3. In terms of which of those is the right answer, we need to consult with the public on that. We also have a variety of models of care, i.e. what services will we provide in Winchester, what services will we provide at the new site, what services will we provide at Andover and Alton and other places. And we need to consult with the public about those service options as well. So those are the things we'll consult about. And again, I'll answer some of the questions afterwards on that if there's questions around there. The other two things I've got on here are the green plan. So we signed off our green plan last year, which is about how we take positive climate action for people and the planet. It's really comprehensive. It's brilliant to have an anaesthetist on this call because anaesthetics have been really engaged, and if you change the type of anaesthetic drugs you use, they have much less of a carbon footprint. So it's everything from that to the transport that we use. Doing virtual online appointments is much better for the planet than expecting patients to drive in if they don't need to. Through to our energy sources, our light bulbs, you know, everything you can possibly imagine. So it's a really comprehensive green plan, really exciting. And then the last picture on here is the molecular hub. I'm amazed the comms team got this photo because this was today. We opened our molecular hub in Winchester, on the Winchester site, and this is brilliant technology which allows us to track the DNA of, I'm going to get this all wrong if there's any scientists on the call, but effectively the DNA of a COVID virus, so that you can see which COVID strain was caught from the same person and which came separately, and you can kind of match whether you've got an infection that's going on in one locality or whether you just happen to have a lot of positive people who have all got it via different routes. COVID is only one part of it. It is going to really help our ability to manage all sorts of infectious diseases, viruses, and they're also looking at bacteria and antimicrobial resistance and all sorts of other things. So really brilliant innovation that's going on in our microbiology department. So that is all of the material I was just going to share. I have seen there's been a bit of chat about the new hospital. So I don't know, should we take the slides down and just have a quick look at some of those before we go into our research? Right. Brian's giving me a thumbs up. Thank you, Brian.
Yeah, there's a few questions in chat about the new hospital programme. There's one from Jen and Chantel about when consultation will be and the status of A&E at Winchester.
Right, so what the latest is, the current situation is that, as I say, we're part of a national programme, and Treasury, the whole national programme went to the Treasury in December to answer the question, how much money do you need to build these hospitals, particularly the phase 2025 to 2030, which is when Hampshire is on the list. So there's already been an allocation made for the work that's going on in different parts of the country up until 2025, but for 2025 to 2030. So the national programme took to the Treasury the full requirement, the full amount of money they need for all of these programmes across the country in December. About the same time, or a little bit before, a new problem had been identified around some concrete called rack concrete, aerated concrete. And there are 5 more hospitals in the country that have this concrete issue. And so when the national programme went to Treasury said, that's brilliant, you've costed up the 40 that we'd originally asked, but could you go away and add in the extra 5? Because we're worried that these hospitals also need significant capital investment. And so the new hospital programme have gone away, spent January and February looking at the 5 additional hospitals that they need to include. And then they're going to go back to Treasury again. Until they've done that, they cannot tell us or any of the other schemes how much money we have to spend. So we know what money we've asked for, and there's a range depending on the options. But we don't know how much money we're going to get. So we cannot consult with the public on options until we know that we have enough funding to deliver the options. Otherwise, we're coming out to the public saying, do you fancy a, you know, amazing, beautiful new hospital? And then we discover we don't have the money to build it. So that's why we're in a slight waiting position right now before we can consult with the public. The second question about A&E in Winchester is this. So that's the public consultation. So public consultation is coming. It's just we can't consult until we know that we're giving the public options that we have money for, because otherwise we'll mislead the public and we'll present options that aren't real. The A&E and the Winchester bit. So Winchester, so urgent care services. So the first thing to say is that A&Es are different everywhere. So today, if you have a stroke in Basingstoke, the ambulance will take you to Winchester. because in Winchester, we run 24-hour a day, 7-day a week stroke services where they will diagnose within an hour that you've had a stroke, and they will provide, you know, life-changing, if not life-saving treatment. We cannot staff that in Basingstoke and Winchester, so we just do it in Winchester. If you have a heart attack in Winchester, they will take you to Basingstoke, because in Basingstoke, we run 24-hour, 7-day a week cardiology services where within an hour of you arriving at the hospital, they will be putting a stent in your heart to open up the artery and to get your blood flowing again. Again, we cannot run 24/7 all of the specialties that you need in 2 places because the demand isn't high enough to run it twice. So, and if you have a major car accident and you need lots and lots and lots of help, you will go to Southampton, because actually Southampton is the tertiary hospital. That means the 3rd level hospital where they can provide neurosurgery and all sorts of things that we don't provide in either Basingstoke or Winchester. So A&Es are different today. What we've been looking at in our models of care for the new hospital is what services does it make sense to run in Winchester, to run in Basingstoke, to run in both Basingstoke and Winchester, to run in, you know, Basingstoke, Winchester, Alton and Andover, and I think Alton came up as a question. So we are trying to understand what is the clinical rationale that says this service makes sense to run in lots of places, like an outpatient appointment, like an X-ray scan, like a CT scan, like a endoscopy check, you know, loads of things that you want to run locally to where people live. And which services make more sense to run once, because you can provide a 24/7 response that you couldn't staff. There aren't enough specialists and you haven't got the money to staff it in more than one location. And so part of the consultation with the public will be about, here are some options. All of the options we've developed include, in Winchester, keeping a 24/7 urgent care service that patients can come to and receive care. The details of what is in that service vary in the same way they do today. As I say, today, if you had a heart attack, they take you to Basingstoke anyway. So that's the thing that will come out in the consultation, the options. So it's very difficult to say, are you keeping the A&E open? Because A&E isn't just one thing. It's about the services that we're running from each hospital. And I'm sorry if that sounded like a bit political. We can talk about this for a long time, but that's where that is. The other thing I would say is all of our decisions around this, or options around this, have been driven by what the clinicians, the doctors, the nurses say provides the best outcome for patients. So we are driven by trying to make sure that the maximum number of people receive a really positive outcome from their experience, and bringing someone to a hospital that can't look after them to the highest standard isn't the right answer for patients. So we're always trying to drive for what provides the best care.
Thank you, Alex. There's a question in there about any plans for Alton Community Hospital.
Right, so Alton, we don't run Alton, the building, although we do run services there. So we run the physiotherapy department there, and we run some outpatient services and some diagnostic X-ray, ultrasound. I was out there a month or 2 ago chatting to the maternity teams who work out of Alton. So the plans for the hospital as a whole, Southern Health run the hospital. All I can say is that we are absolutely committed to continuing to run and expanding the options of the services we put out there. So the diagnostic services, the outpatients and things like that. So we work really closely with Southern to make sure that we can provide as broad an offering as possible to Alton and the people that work there and live there. So yeah, I don't know about any specific plans for the building. I know we added Southern Health added an extra ward, so there's now 2 inpatient wards. Hopefully that gives confidence that people aren't disinvesting in Alton, they're investing in Alton. But that was a Southern Health piece of work rather than Hampshire Hospitals.
Thank you. And just before we move on to the next speaker, there's a question in here about what plans are in place for your EPR to go from paper light to almost paper free.
Paper light to paper free. This is a very good question. So and I'm just wondering, I don't know, Lara's not on this today, or Tim maybe, but right, electronic patient record is what EPR, for anyone that doesn't know that term. So our electronic patient record is would I say reasonably comprehensive. We do a lot of stuff on the computer. So we have, for most of our services, and some of the clinicians on the call might want to say, we keep most of the information on the electronic system. There are some departments and there are some connections where that isn't the case. And what we have is a program that turns more services onto electronic formats. Last 2 years, the big thing's been maternity. So there's a system called Badgernet that's gone in. So we don't expect mums to wander around with little booklets with all of their data in. Instead, it's all on a thing called Badgernet that has an app on a phone. So the mums and dads can download the app and use the app for their records. And then the folk in the hospital can look on the computer to see it. So we are in a journey of moving things onto an electronic system. What I can't tell you right now is when that whole program will complete. Part of that involves scanning all the historic paper records into a computer system, and that program will start scanning. I can see Charlene on my screen who knows all about it, but we're starting to do some of that scanning in the late spring, early summer this year. It's getting all of the system configured so that when we scan it in, clinicians can easily access it again. It's not just like some massive long list of files that you'll never find what you want. So yeah, it's definitely part of the journey we're on.
Thank you very much. Just to note, our colleague has put contact details in the chat about the new hospital programme. So if anyone has any questions, then please do email that and then we can get back to you, just in the interest of time.
Yeah, Chantel, yeah, contact Elia. I think we have been trying to get hold of you, so I don't know what's going on there. So yeah, okay, we need to do that.
Yeah, so I think we'll move on to the next speaker now, which is Siobhan Laws. Welcome, Siobhan.
Good evening. Nice to see everybody, even if it's only little pixels. I've been asked to, I'm supposed to ask you a couple of questions first, aren't I, Grace?
Yes, we've got a couple of polls to put in. I'll just launch that now. So it'll pop up on your screen, everyone. If you could just submit an answer for us, that would be amazing. Should be on your screen now.
So we'll just give you a few seconds to complete that, and I'll waffle on in the background for a minute. I'm the clinical lead for Research Hampshire Hospitals, have been for the last, I think, 4, maybe 5 years. And prior to that was deputy lead and lead when we were a separate hospital at Winchester. I'm a breast surgeon by background, and that's what I do most of my daytime activities. Shall we move on to the next slide? What we've been working on over the last year or so, as soon as we caught our breath after the COVID thing, was a strategy. How are we going to get from being a relatively small research active unit into something that's far more sustainable and gives more patients, staff and colleagues access to getting involved in clinical trials. So we've developed a strategy document which will be going to the available publicly in the very near future, and it's just looking at how we can increase what we do and make it work for everyone. And we've got lots of ways of doing that, but again, as Alex has said, we need to do this within a reasonable budget, and the money from government has been static over the last few years, so we have to find other ways to bring in funding. If we go on to the next slide. So these are just some of the areas that we're research active in. This slide shows women's health, microbiology, public health, orthopedics and other musculoskeletal such as rheumatology conditions. Got a lot of work going on in critical care. We've had a lot of work in the emergency department. Respiratory teams are active. We've got lots of stroke work. And if we go on to the next slide, it shows some more. Couldn't fit them all on one page. So I've mentioned rheumatology already. We've got children's health, we've got blood disorders, lots of heart things, various cancers and various other gut problems as well. And this involves a whole range of clinicians, from clinical scientists, nurses, right through to some of our consultants. And next slide. So I was just going to give you an idea of some of the range of studies that we get up to. We're going to be talking about Harmony later on. This is a study we've set up in collaboration with industry, and it's looking at making sure that we can look at how we can protect some of our youngest members of our society from a very common but can often be quite deadly virus called respiratory syncytial virus with a vaccination. And we've recruited really successfully to that. Recovery and REMAP-CAP have been absolutely instrumental in helping us understand COVID, and Irina will talk to you a little bit more about that. And that they've got some quite unique designs that have been really helpful and will help deliver research more efficiently in the future. Optima, I can't remember if that was the Optima I know about. So one of the Optima trial that we've been involved with is a breast cancer trial. It's looking at whether we can reduce the amount of chemotherapy we give to patients. Do you really need to have it? And that's quite an important thing, is are we able to de-escalate treatments? Embed is a lot of my patients ask me, oh, what blood tests are you going to do for me? How are you going to detect my cancer coming early or a cancer coming early? And Embed is a collaboration with the University of Cambridge, and we're asking people to donate blood samples when they come for high-risk breast screening to see if we can pick up some really early changes in their blood, and that could be really quite exciting. Walk is a study that we're sponsoring, which is one of our respiratory physiologists has set this up themselves, and it's looking at ways of interpreting results of stress tests to see what's going on in people's lungs. Hepatica and Connor were two very big grant-funded studies that we've done, looking at how we can optimise preoperative planning for liver surgery. Dr Ramage has been instrumental in getting a lot of the EORTC studies, which are international studies, and looking at quality of life for certain conditions, and making sure that when we measure quality of life, which is really important to us. I did have a patient recently who thought we weren't interested in that when we did clinical trials. We're very much interested in quality of life, and it's a major part of what we put in trials, but it's important when we measure quality of life that we do it accurately and with evidence that it's the right way to go about it. The 100,000 Genome Project was a really exciting national study that looked at reading the entire genomic sequence of 100,000 patients and their relatives. They were all linked to each other, and the results from that are coming online. They've looked at rare diseases, they've looked at cancer, they've looked at child developmental problems, and the stuff that comes out of that will be really interesting. I'm particularly interested in the Target trials because that's a trial of intraoperative radiotherapy, and that's allowed me to develop my clinical practice in breast surgery, being able to, again, de-escalate the amount of treatment we give to patients, and we can do so safely, and we have the evidence to do that. It's now part of our standard treatment programme. Pair 1 is a study that looks at how to interpret MRI scans on prostate cancer. We've set that up again with industry. We've collaborated with a number of other NHS and universities, and that should help with the interpretation of MRI scans of prostates and allow us to do more scans or the interpretation of the scans in a quicker time period. And that's a really interesting collaboration for us. We haven't done something like that before. We've done emotional well-being studies, particularly as a consequence of the COVID, but there's lots of those sort of studies that go on in the background. Falcon study was one of the ones that our microbiology team got involved with, and coming out of that, that's how to rapid analysis of COVID tests. So lots and lots of exciting stuff. And adverse is another way of managing complications of major surgery, and that's another collaboration with industry. So you can see we've got a whole range of different types of studies that are going on and this is just a snapshot of them that are going on in the trust. So we've got lots of collaborations. We collaborate with industry. We're looking at whether we can collaborate more with a science park. We've got a bus that we've been loaned, and you'll see it around eventually when we've signed off all the paperwork, which hopefully will be anytime soon. But we'll be able to do more work. We haven't got enough clinical room in hospital, but we've now got some extra clinical rooms in the bus, and there's a little mini laboratory in there as well, so we can sort out blood tests and so on. So that's another way that we can collaborate, and that's been funded by the local research network. We're really keen on collaborating with our GP and community colleagues to get seamless research across all the different healthcare systems which are currently in silos, and we'd really like to make it easy for studies to they might start in secondary care, they might end up in primary care, or it may be something that we do in the community. But if we can have all that information and the patient journey is seamless, you don't have to come to the hospital for us to be able to do the study. You don't have to do the study in one GP practice. It can be seamless, and that's what we're looking to set up. And the main universities we collaborate with are the local ones of Southampton and Winchester, but there are other pockets where we do collaborate with specific universities. Next slide. Sorry if I'm talking too quickly. I wanted to talk very quickly about big data because it receives a bit of a bad press, but there are some things that we can get such a powerful bit of information from being able to look at data. And we were able to put in for a grant to look at length of stay for patients who've come into the hospital with chest infections, and try and predict who's going to need more care, who's going to stay in hospital longer, who can be managed at home, how can we predict what the capacity in the hospital needs to be. And this is really important work that we need to do in planning for the future. And we were lucky enough to get a significant financial support for that. And on to the next one. I think you'll remember right at the beginning of COVID, we didn't really know how to manage COVID. And what we set up, and by collaborating with Southampton Data Science Unit, with the South Ambulance Service, with our GP partners, we were able to set up this integrated care of patients who didn't need to come into hospital, but we could monitor them safely from the hospital. And one of the simple ways of doing that is to measure the oxygen circulating in the blood. And you can get that, put the little picture from Amazon on, you can get that on Amazon. So it's a little gadget that is available to everyone. And we did give them out in the early days, so people could be monitored and they could be safe at home. And we were only able to do that because of the data that we collected in the early days. We collected the data in those first few months of COVID. It was published towards the end of that first year, and that made a really big difference to the overall care nationally. And it was very important stuff, but relatively straightforward to do because we had that data. And on to the next thing. And the reason why I'm waffling on about the data is that we do want to be involved with the trusted research environment, and the local care partnerships across Wessex are going to be involved in setting these up. And this is about making sure that when we use this really important data that we have, that we do it in an ethical manner and we do it securely. And so it's making sure that we are responsible as members of our community for all the things that are right about this project. And there's lots more information from on the website, but the data that we can get from it is absolutely vital for making sure that we plan care and that we can get information for implementing speedy and safe change. I was involved with the 100,000 Genome Project, and the way that they set up the data security in that, so that we've got patient information, patient data, as well as their genomic data, but the way it's held is very secure, and the way that third parties can access is very ethical, so that you have to have a really good reason for accessing the data, and you can't take any patient identifying information out at all. So there are lots and lots of ways in which you can be really careful and ethical about how the data is used. Sorry, moving on to the next one. And what helps us make sure that we've got our feet on the ground and that we are ethical is involving our partners in the community. And as a part of that, we've appointed patient research ambassadors, and these are people who are part of our team, but they're very much about telling us what's going on in the grassroots level. They help and support patients through a research journey. They help inform when we're trying to set up a trial. Oh, that doesn't sound good, you can change that. And it also helps us reach out to various staff and communities that might otherwise we have difficulty championing. So we're really pleased to get these people on board with us. Oh, and I finished. Excellent. Hopefully that wasn't too much of a ramble through that.
Thank you, Siobhan. There's a couple of questions that have come in the chat. First one, are you planning any research into patient-initiated follow-up and virtual wards with AI?
With AI, I'm not aware of any at the moment with AI. We're certainly using AI to inform what we do in the virtual wards, but not actually AI to run these things. We've still got humans in there at the moment. All of these things are not off the cards. They've just, if we're going to sort of look at them, we have to make sure that they're going to be done in the right way. Patient follow-up, the important patient-initiated follow-up, the important thing about that is that patients can then access us when they need to, but that we make sure that they get appropriate surveillance when necessary. And so there may be an element of AI assistance with that, but it would be assistance rather than a takeover.
Thank you. And I'll go for another one just before we move on to the next speaker. What are the main studies taking place in neuroscience and psychology?
So we've got some, we don't tend to do basic science ourselves. So in the laboratory, apart from our microbiology team and to a certain extent the pseudomyxoma team, a lot of our basic science stuff. So if we take a sample, for example, and it's part of a research study to be analysed, to be looked at, the cells to be fiddled with, that tends to be done in other institutions where they have the appropriate backup. What we're doing is approaching people and giving information about their overall care and the data. So from the neuroscience point of view, that's going to be done elsewhere. We do collaborate on trials where those things are important. We've had a lot of stroke trials in the past, for example, and there's a couple I think still open at the moment. I did put those up on the on one of the slides earlier on, that is one of the areas that we're really keen that we get going. Psychology, we're starting to do more and more collaborations with the University of Winchester. They have a big psychology department, and they try and get involved with that. The pseudomyxoma team have got a psychologist on their team, and they're doing amazing stuff, really interesting stuff coming out of that. And there's lots and lots of stuff that comes in, gets done, gets moved on, but we're open to any type of research. We're not restricted to the subject or the specialism, as long as we've got the right patient and staff base, basically. There's no prejudice one way or the other. Anything, we'll do anything if we can help.
Thank you very much, Siobhan. Just before I hand over to Irina, I just want to say thank you to Jess Johnson, who's put a note in there about the work that Action Hampshire are doing. It sounds really good, so I'm sure we or anyone else on the event will be in touch. Moving on then, I'll introduce Dr. Irina Grecu. Welcome, Irina.
Oh, hi, thank you, and thank you everybody to be here. It's amazing to see how wide participation we have. I already wrote down the email of Jessica Johnson. Thank you very much. It's really interesting what you wrote there, and I will follow up on that. And I am really thrilled to be here. I am an intensive care and anesthetist consultant. And I've been involved in research since my first year of training in medicine. And I do believe strongly, I'm biased now because I've done research, as I said, from the very first day, that doing research and being aware of how research should be run and what the evidence, how to read a medical paper and how to interpret critically the evidence from all this makes me a better doctor. And when I speak to my patients or the relatives or the patients, I am able to offer a large variety of options of what may happen and what treating options we have. And in intensive care, as you all know, it's very bleak usually. Once you get there, nobody is trained how to deal with being a critically ill patient or being a relative of a critically ill patient. So it's quite a very traumatic experience. And knowing the data available and being part of developing this data, for me, it's amazing. Okay, if we can get to the next slide. I put this just to show you that what the General Medical Council, who's regulating the doctors, as you all know, put standards for a good medical doctor, for what it means to be a good doctor, and what is the good practice in research. They are actually the same principles, and by being involved in research, the doctors keep this practice at a very high level. And it's all about, you know, confidentiality, communication. We talk about informed consent about the procedure, but it's very difficult to somebody who is a lay person who does not have training in medicine to understand all the options on the table and to understand the consequences of the table of the options. So in research, the information we need to provide to people, patients participating or even outpatients participating in research is very comprehensive. So it is much more than probably you will get on a quick consent before a surgical procedure. So I really love that. Thank you. Next one. So medicine is a very fast advancing science, and clinical research means, you will hear in Emma's, our next speaker's talk, that clinical research is the top, the end of research that starts in the laboratory. It's basic science research. Clinical research that we are doing involves patients. And because it involves patients is extremely powerful because it lives. It's about us, about you, me, and our relatives, and it's about our lives. And the speed of new treatments and new procedures, new drugs introduced in the last years is absolutely mind-blowing. To me, as a who's done research for 28 years now, it's still mind-blowing. And I'm going to stop at the example of COVID, because Siobhan already mentioned, I'm going to stop on that. When COVID hit the whole world, we were in a denial period initially. We were just thinking, oh, it's not going to happen to us. It's going to stay like other epidemics or pandemics back in Asia or in China or whatever. It's not going to hit us. We are far away. And then it hit us hard, and it hit us quickly. And we had no drugs, nothing. It was a bug or a virus coming from an animal. there was absolutely no evidence. And when I say evidence, it's previous research done on that. And the way that the medical community mobilized worldwide to develop research studies like Recovery and Remap CAP, which we participated in successfully. It is an absolute first time, and it is clearly that this is the future, because we will see more of these problems in healthcare in the future. I don't want to be, pessimistic. You might call me an intensivist, but that was really, really hard hit for us. And these trials, Recovery and Remap CAP, were using an adaptive platform, which means that treatments were studied against control, against placebo, which everybody knows what placebo means, or against other treatments that were used in other viral infections. And as they were proved not to be effective, they were dropped. So we were quickly getting rid of initial drugs, which were like the malaria drug, the hydroxychloroquine, and other antivirals that were promoted, or some antibiotics that were promoted initially. But doing this at an international level, multi-center, with a collaborative that included thousands of, hundreds of thousands of patients, and an enormous amount of patients enrolled in that, we were able to drop the ineffective treatments very quickly and to identify something very simple, like, you remember steroids? Let's go to, this is the last slide. Yeah, go to that slide. Do you remember steroids? They are such a cheap drug, and we use them in a lot of diseases, in asthma, and a lot of rheumatoid arthritis or whatever. We use them in a lot of disease, but in viral infections before, it was thought that it's a no-no, because the viral infection can be complicated with another infection, and the steroids are basically decreasing the immunity. So the body will not be able to respond to a new infection if they are receiving steroids. It's an immunosuppressive drug. And look what it did to COVID. My God, it was the biggest clearly the biggest advancement. And I have the permission of this is a patient that we had in the first wave of COVID. The photo on the left was taken by his wife when we called her at the bedside to tell her that there is absolutely nothing else that we can throw at him and he's gonna die. And you may or may not know that, but the only time when we allowed relatives to visit during COVID pandemic, especially the first wave, was if they were in an end of life situation. She came and took this photo, and I'm going to become a bit emotional now, but this is the same patient now. We threw steroids at him, and massive steroids. And yeah, I have no words to describe what amazing things research can do for everybody. Thank you. I'll take questions.
Thank you very much, Irina. That's a lovely story to end on as well. I have seen a few colleagues replying to questions in the chat, but I haven't seen any new questions come in.
Later on, if anybody has, just put them in the chat.
Yeah, we can come back. That's fine. But yeah, I can't see any new questions, so we'll move on to Emma now. Welcome, Emma.
Hi everyone. My name's Emma. I'm one of the research practitioners in the trust. I'm a nurse by trade, and we have a group of about 50 nurses, midwives, allied health professionals and healthcare assistants who help us to deliver the research studies. And I'm going to talk about some of the nuts and bolts of what it actually is like to take part in research. So first of all, the question is, why do we do research in the first place? And going back to the sort of root of what we do, the NHS Constitution, one of the pledges in there is that we will inform you of research studies in which you're eligible to take part in. And the reason for that is one of the principles about providing the highest standards of excellence and professionalism. And Irina talked about that as well when looking at the GMC and the doctors, and it's the same for us nurses as well. We have to provide evidence-based care, and the only way to do that is to help produce the evidence. So that's some of the reasons there. Also, thirdly, we know that research active hospitals have better outcomes for all their patients, not just those who are actually taking part in the research studies, but for the whole population there. So we're really keen to ensure that, you know, we can increase that standard of care for everyone. And then on an individual level, we do research so that we can offer you more opportunities. Sometimes it's an opportunity to have a say in your care, or to improve potential care for the future for other people. And sometimes it's about different opportunities in your own care, and perhaps being able to access treatment or new gadgets or something like that that otherwise wouldn't be available to you. So there's some very good reasons why we do research, but it's not all of them. And then what actually is research? So I've obviously used the word quite a lot tonight. I think, as we said, Siobhan said earlier on, sometimes it's research in the lab on samples. We don't do a huge amount of that, but our teams in the molecular hub certainly will be doing. Sometimes it's about looking at data, and sometimes that's really big data where we do those big data partnerships. I recruit patients to take part in a big study about inflammatory bowel disease, and the idea is to create a really big data set of about 50,000 patients, where we've got some really solid numbers there. Sometimes the research we might ask you to be involved in is something like questionnaires, or what we call observational studies. So that's where we look at what's happening to you and track that. Sometimes we're looking at really long-term outcomes. My studies tend to be quite short, but some of my colleagues in the cancer research team might be following you up for sort of 25 years or so. So it's really long term. And then we have those groups of studies, which are perhaps what people think of when we ask you to be part of a research study, and that's that interventional studies where we might change your treatment or offer you a treatment that's not been licensed yet and is still experimental. But actually that's only a small part of the big picture of what research is. So some of the things that we might ask you to do as part of research. So we might ask you to answer some questions, and we might ask you to donate blood samples for genetics or other samples. So in my inflammatory bowel disease work, we obviously collect quite a lot of stool samples and gut biopsies, and all their specialities have got their own sets of samples they might collect. So we might ask you to try some new treatments or different ways of using the treatments that we already use, trying to use them more efficiently. So a bit like Irina told us about using steroids for COVID, that, you know, those have been around for donkey's years, but actually we found a new way of using them. We might ask for permission to look in your medical records and link those up and collect the data through there. So I spend quite a lot of my time leafing through our old medical records. So that's the bit that's not electronic yet. And it might be a single episode when we see you, or we might be following you for a number of years. Sometimes we might ask you to do some additional tests or procedures to give greater understanding to what we already do. So where does research happen? Well, research is generally happening all around you. Sometimes it's in the background, using some of the data to work out what we're doing and how we're doing it. We try to provide research opportunities at all the trust locations. We mainly do that at Basingstoke and Winchester, but currently we're doing a study at the hospice in Andover, and sometimes we get to travel over to Andover to see patients and outpatients there. So sometimes the research happens alongside or in parallel to your current care. So you might come along to the hospital because you're being treated for something, and that might be a really great opportunity to connect with the research team and for us to ask you to take part in some research. And sometimes we might have to ask you to come in some extra times to see us in order to do the research. And we try and make that as easy as possible for you. So how does it actually work? Well, we've got a team of research specialists, nurses, midwives and AHPs, like myself, who actually do the everyday project management of the studies, and also look after our trial patients. We're usually part of a network. A lot of the studies that my colleagues have talked about earlier on are what we call multi-centre studies, and that means that we are just one site that is recruiting patients, collecting the data, and then we send it back to the researchers who are at the centre, and they will be processing the data and analysing it and publishing the results. So we're, as part of that that network, we can really deliver really big numbers and actually have some really reliable outcomes. And I just wanted to put in there that taking part in research is always optional. It's always up to you. So we will come to you and say, would you like to take part in research? And you can say yes or no, depending on how you feel about it. All right. So how can you get involved? So if you're one of our patients, you can ask your clinicians about opportunities to be involved in research and say, is there any relevant research projects? There is a portal, and Grace has put the links to that portal on the next slide, where you can look for relevant research projects relevant to you. You can sign up for our newsletter and find out a bit more about what's going on at the Trust research-wise. And you can also become a research ambassador. So I know Siobhan talked about our research ambassadors earlier on, and I think I've seen at least Bill is here today, which is great. We would love to recruit a few more patient research ambassadors to take on that really, really important role of helping advise us especially when we're developing our own research projects as a trust. So if you're at all interested in finding out more about that, please do get in touch with us, and we can have a discussion about that one. And staff as well. So hopefully we've got some staff on the call today. If you're interested in knowing more about how you can help deliver research, please talk to the research delivery team in your speciality. Sometimes, you can just take some roles on supporting us delivering the research, or a bigger role in delivering the research like Irina does, or even leading it and coming up with our own research projects. So there's lots of opportunities there. And so this is the slide with the portal. So the B part of research, under the banner of the National Institute for Health Research, you can search all the studies that we've got open, and then we've also got our contact details down there on the bottom right hand corner for the research team as well. I think that's me done.
Thank you very much, Emma. There's a couple of questions that have come in. One from Sue saying, do you have any challenges in harvesting the data for your evidence if there are hybrid ways of working, thinking about hybrid sources of data?
I mean, certainly that's something that I do every day. Once we've got the consent from the patient to take part in the research study and collect the data, we know there's quite a few different places we have to look in order to get the whole picture for the patient. So we're looking at GP records, we're looking at our EPR. I'm going through the historic Brown medical records, which are our sort of classic notes, and we put it all together. So there are some challenges, especially all these fantastic new systems. We have to be able to access all of those as well to get the whole picture.
Thank you. The next one from Bill. Sue has put an answer on there, but I don't know if you wanted to expand. He said, how easy is it to get data from primary care?
We tend to get a partial picture, I think, from the data there, but usually from my purposes it's enough. I think different clinicians will have different sorts of data sets they need, and we might need to have a more direct way of getting that data if you needed it for your research study, but that's usually study by study basis.
Thank you. We've also had a couple of questions about getting involved in research studies as college students and volunteering.
I guess you can always email us at research.team@hhft.nhs.uk. It really depends on what sort of research project you wanted to get involved in, and all those sorts of details. So that's probably best to have a conversation with us. So please do drop us a line.
Thank you very much. I can't see any more questions. So before I move on to our next speaker, I'm going to put the link in the chat to the Jamboard with the other couple of questions. Did you just want to speak a bit about that?
So we wanted to use this as an opportunity just to ask you, our community, what sort of research do you think we should be doing, and where do you think we should be doing it? We've talked a bit about bringing healthcare close to the community, opening up some of our, GP surgery and our diagnostic hub in Andover. At the moment, a lot of research takes place at the hospital when you come in. Over the pandemic, I certainly had to resort to video calls and phone calls to follow up some of my research patients. And it's just about how would you like us to work in the future so that everyone has a chance to get involved in research. So any thoughts on that, please do add it to the Jamboard, and it will be really, really interesting to develop what we're doing. We've also, Siobhan alluded to the research bus, and I believe that is turning up later this week actually at Winchester. So we're very excited about how we could use that as well.
Thank you. So I'll move on to Dr Madiha Aziz now, who's going to speak a bit about the research trial that her son's in. Hi, Madiha.
Hello. Hello, everyone. I appreciate I'm one of the last speakers, so I'll try to be brief. But yes, as Grace mentioned, I'm one of the doctors working at the Trust, and my son has recently been enrolled in the Harmony study, so I'm just going to speak about that briefly. So I am a first-year GP trainee, and I recently finished a rotation in the pediatrics department at Basingstoke Hospital, and that's where I came across this study. So the Harmony trial is a clinical trial that's looking at how strongly babies can be protected from serious illness due to RSV infection by giving them a single antibiotic dose. So RSV is a very common virus. It causes a lot of admissions for babies under 1 year of age, and it's one of the most common hospital admissions in the UK in that age group. And about 90% of children under the age of 2 have been affected with RSV. So this particular virus, it can cause a wide variety of symptoms. So sometimes it can just be a very mild thing like a cough and cold, and other times it can progress to something like bronchiolitis or pneumonia. And in such severe cases that babies actually need some support with how they're breathing. So this study essentially is looking at the effectiveness of this vaccine to kind of reduce hospital admissions. And especially, as I mentioned, it's a wide spectrum. We don't really know how a particular baby is going to react to that certain virus. Even in previously healthy babies, in just a few days' time, they can become so ill that they're kind of needing that ventilation, the respiratory support. And it is quite difficult to look at. So working in the peds department, I saw a lot of poorly babies come in. And when I found out about this trial, I thought, if there's anything that we can do to kind of prevent these kind of infections from occurring in the future, then why not do our part? So again, that was one of the main reasons for enrolling in the trial. Another one of the reasons was that I've previously been involved in research. So not now, but many years previously, when I was in university, I was doing a lot of clinical trials, and it's so difficult to get participants. So that was always running in the back of my mind to, if I ever had a chance to kind of participate, I would. Another reason as to why we enrolled was, that immediate the immediate protection that the vaccine could have provided for my son. And that's something that he did get. So he did end up getting the vaccine, and I am grateful that he had that added protection throughout the winter. I feel that's been really helpful. And one of the other reasons as to why I did it. So sometimes it's quite difficult to enroll into something that's quite new, But something that gave me the confidence for entering into this trial was because the vaccine is not particularly new. So this vaccine has been tested previously in about 3,000 babies, and they found that it does have promising results. It does kind of reduce the severity, and there was a considerable safety margin as well. So that kind of made it easier as well to kind of participate in this trial. And again, working in the pediatrics department, I was also in the postnatal ward, kind of convincing families to kind of go for this, to go for the research. And if you're telling someone to do one thing, then you should kind of, take that initiative to get involved in it yourself. So all of these reasons kind of culminated into my son being enrolled, and he was about 10.5 months at the time. So still well within the age group. So the study is looking at newborn babies up until 12 months of age. So the process of getting involved, we basically just sent an email, and we got an email back kind of going through what the study's about. We filled in some consent forms as well, and we just booked in an appointment. So at that appointment, staff was very friendly, everyone was very kind. It was a very quick appointment, and that's when we found out if we're either going to be in the intervention group and receiving the vaccine, or if it's just going to be in the control group. And so he did end up getting the vaccine. We waited about 30 minutes in the waiting room, and that's it. We were fine to go home. And since then, it's just been a monthly diary that we complete, and that's just on the phone. So just very simple yes or no questions, not really requiring us to do anything extra. And we're just going to get a telephone call in about 1 year's time, and that's going to be that. So that is basically very little effort that's being put in. And also during the appointment, there was also consideration being given to like the cost of driving to the hospital, and also the cost of just parking. And it was just little things like that kind of, it was just something added, just something extra just for the participant. And that was something that I did really appreciate. So again, as I mentioned, little effort, very easy process, but has the potential to have a really big impact for babies in the future. And I don't know, I just like the idea of when my son gets older, I can tell him, oh yeah, you participated in this, you had a hand in kind of improving healthcare for other kids. And I don't know, I'm just glad that we were able to participate in that sense. So again, the study has the potential to kind of reduce hospital admissions in babies. It has the potential to reduce the severity, reduce the degree of illness, because again, I saw so many poorly babies. And with this infection in particular, there's no particular treatment that we can give, no specific treatment. It's just supportive treatment that we can give. So sometimes you'll see a baby working very hard with their breathing, and it feels bad, just kind of seeing them in that state. But if, again, now we have something that can kind of prevent that from happening. And yeah, I encourage whoever can get involved to get involved. So I was lucky enough that I was working in the department, and that's how I found out about the study. But if I wasn't there, I think it would have been a lot more difficult for me to come across that there was a study like this going on. I did receive a text from my GP, so that was quite helpful. But again, I just like to encourage everyone to kind of discuss it with their friends and family, just to see if there can be if we can just get more participants in this, because I think we're trying to go up to over 20,000, which is quite a lot. And it's not just in the UK, also in Germany and France. So yes, the more participants, the better. And again, I've just run through a few reasons as to why we did so. And I think that's about it for my talk. 28,000, thank you. Any questions?
Thank you so much, Madiha.
Oh, perfect.
I can't see any questions that have come through. So if it's all right with you, I think we'll just carry on. But thank you so much for sharing your story. Hopefully it inspires some more people to get involved in research. Just before I move on to closing thoughts with Alex, I'm going to share the results of the poll that we filled out at the beginning. So I wonder if Siobhan, you'd like to reflect on the results that have come through?
Oh, there's a good amount of people that have been involved in research and a lot of people who'd be interested in taking part. So I think that that's fantastic. I don't mind that people don't want to take part in research. It's entirely your choice. But you might find that there is a study that is interesting to you and there are other studies that you don't want to get involved in. And I think Emma gave a really nice presentation of what might be involved. So things are not always, sometimes when we approach people, they're really happy to get involved because that's what they want to do. They want to share things, and if it's easy, that's fine. Other times, if it's taking choice away from you, they don't want to get involved. So sometimes the design of these research has to be carefully looked at. And that's one of the reasons why we like to get involved with patient groups and the public in forming studies. We're just about to open another breast cancer study, and it's got very, very heavy patient groups that have been involved in the design and setup of the study, with lots of different nuances within the trial that has been directed by the advice that they've been given by the patient. So I think from that point of view, there's a lot more that can be done, and it makes a big difference when people get involved and they're bought into it. And I think you can see from where's she gone? I've lost it now. But when Madiha, when you're involved in it and you see things that are happening and you see people that have been affected, and you see how you can avoid that, that's when it makes it real for you. So it is really important. But we'd like to see more people who want to get involved in research being able to take part and doing things that they want to get involved in. So I think that's important as well.